Welcome to the latest episode of What Your GP Doesn't Tell You, the podcast for both doctors and patients with me, Liz Tucker. In this week's episode, I'm talking to Dr. Louise Newson, who I met recently at the Integrative and Personalised Medicine Congress in London, about how to use hormone replacement therapy, or HRT for short, effectively in women. HRT is a subject that has been much misunderstood. Too frequently, women in either the years leading up to the menopause, known as the perimenopause, or during the menopause itself, get misdiagnosed when they go to see their GP about symptoms. That can mean they end up on antidepressants, sleeping pills, and potentially a cascade of other drugs, some of which may be very difficult to stop once they're started, and of course don't actually treat the symptoms of the menopause. Shockingly, Louise has even met women who've been given electro-convulsive therapy for their menopausal symptoms. So we're going to discuss what are the hormones you can take and what form should you take them, and just how safe is HRT. And initially, all I thought we'd be talking about in this podcast is Louise's work and the work of her clinic, of which she's a co-founder. However, you may be aware that a few months ago, a British BBC TV programme called Panorama queried why Louise prescribed higher levels of estradiol to some of her patients. The clinic has worked with more than 40,000 women, and Panorama alleged that 15 women treated there that it spoke to had experienced complications. 4 former doctors who'd worked at the clinic also expressed concerns. Louise was not given an opportunity to appear on the programme to respond to the allegations, but I thought these were really important points that we should address. So this podcast with Louise is in 2 parts. The first was recorded before the TV programme was aired, and the second discusses the issues raised. But before we get to Louise's interview, a brief request from me. If you enjoy this podcast and would like to leave a review on Spotify or Apple, that would be much appreciated. It really helps. You can also become a paid supporter of the podcast at patreon.com/whatyourgpdoesn'ttellyu or via PayPal on my website, whatyourgpdoesn'ttellyu.com. A huge amount of work goes into both the research and production of this podcast, so even a small amount of money makes a huge difference. And you can find out more information about the pod on my website, where you can sign up for the podcast mailing list, follow me on Twitter at Liz C. Tucker, and on my Substack account, liz.tucker.substack.com. Many thanks. And now back to Louise's interview. Dr. Louise Newson studied medicine and pathology at the University of Manchester and followed a career in hospital medicine before moving into general practice. She's a menopause specialist and member of the UK government's Menopause Task Force. Louise has also developed a free menopause support app and website called Balance Menopause and runs her own Dr. Louise Newson podcast. In 2018, she founded Newson Health, which offers perimenopause and menopause treatments for women across the UK. Here's her interview. Well, Louise, thank you so much for joining the podcast today.
Oh, thanks for inviting me, Liz.
Louise, it's more than 20 years ago since a study called the Women's Health Initiative linked HRT to breast cancer, which I think's had a long-term effect for both doctors and patients in avoiding either prescribing or taking HRT. But I think you'd argue that when you dig into the details, it's actually a more complicated story.
It is a complicated story, and there's lots of things, aren't there, that are against women receiving their own hormones. But it's important to know that this study actually has, I think, and many others do as well, it's been the biggest harm for women's health ever. It's been so misinterpreted. I can't think of any other study that's been analysed as much as the WHI, the Women's Health Initiative study. But actually, the other thing is that I find almost it's either laughable or frustrating. I'm not quite sure which, depending on my mood, is that we're actually talking about a study using hormones that we don't even prescribe, or I certainly don't prescribe, because we have to remember this study was using conjugated equine estrogens. So that means hormones that were derived from pregnant horses with synthetic progesterone, medroxyprogesterone acetate, which is used a lot in contraception, but they're synthetic. So they're chemically very different structure to our own hormones. So now when we prescribe the natural hormones that are biochemically and structurally the same as our own hormones, of course they have metabolic effects. So it's like talking about thiopin compared to an SSRI. It's completely different. So it seems almost irrelevant to keep talking about this study.
If you ask many GPs now, they'll still say, oh,
Yes.
HRT, breast cancer risk.
I think the problem is it's really hard to change perceptions. You need to just look at just some of the data that's out there that has been so misinterpreted, but also some of the websites. You've got cancer research telling us that if women reduced HRT, there'd be less breast cancer. When, as doctors, we prescribe hormones, we have an alert that is linked with MHRA saying risk of breast cancer, especially if it's used for more than 1 year. It doesn't even say younger women or body identical hormones or vaginal hormones don't have this risk. And then for me as a patient, every time I open my patches, there's this long thing telling me risk of breast cancer. So then who do you believe? And that's really difficult in medicine, isn't it? When we have confusing messages. Is it this person who runs a private clinic, or is it the person that's in the MHRA, or is it the neighbour in the street, or is it Dr. Google? Where do we believe and who do we go to? All the information or misinformation stems back to the WHI.
And I suppose people might argue, you run a menopause series of clinics so that you have a commercial interest, therefore, in persuading people that it is a good idea to take HRT.
Yeah, and I think that's really interesting. And I think the most important thing in this conversation is for people to know I do no paid work with pharmaceutical companies. And I've made that decision when I set up Newson Health as an organisation. And that to me is the most crucial thing. The other thing as an organisation is that we fund a lot of much needed research. We fund the free Balance app, which is free. I've never had external investment for my work. So it's really important to know, yes, but what we're doing is we're seeing thousands of women who are underserved in the NHS from all socioeconomic classes. The clinic also enables me to do a lot of outreach work. Some of it I don't talk about publicly, but I have been, working in prisons. I work in all sorts of areas that I couldn't do if I was a full-time NHS GP because I wouldn't have physically the time to do it. It's a weird sort of business model, actually, the clinic. I never realised there was so much suffering. But actually, we also have to look at who else has got on the agenda here. We have to look at the other menopause societies and specialists who do work with pharmaceutical companies, who you could argue do have more of a vested interest. I'm very interested in basic science. So a lot of what I do is about basic science, and also a lot of what I do is about enabling people to have a choice. My measure of success is not seeing patients. It's about enabling people to have the knowledge and information that they can get information and treatment, more importantly, themselves.
But I suppose it's difficult, isn't it, Louise? Because obviously you have to cover the costs of the business that you run. And because you're not in the NHS in terms of the menopause clinics, obviously, I'm assuming, therefore, it may well price some women out of seeking your help.
It absolutely does. I mean, it's frightfully expensive doing any sort of private medicine. But actually, the reason that I can sleep at night is that I know that I've given so much free resources to people. I've got my website, I've got my podcast, I've got my YouTube. So I think it's hard to say that all I'm doing is creaming off for women. We also work really closely with GPs in the NHS, not only training them, but also giving really detailed clinic letters. And often when people are on the right dose and type of hormones, the GPs then take over prescribing. So we don't actually encourage people to keep coming back to the clinic, which again is different. I drive my FD mad. In fact, yesterday we had a conversation about the number of free appointments that I give under the radar to people. But, we didn't go into medicine to be entrepreneurial, to make money. And if I start thinking about money, it will change my focus. So I'm very fortunate. I'm not part of the exec team. I'm not making the strategic decisions about finances because that would worry me too much. I employ too many people. My focus is to help as many people as possible.
Do you think there's still a thought in a lot of quarters that the perimenopause and the menopause are just part of aging, and that to start giving women HRT is medicalising what should be a natural process?
Yeah, and I really like that question. There's a few things. Am I allowed to answer in more than one way?
You are, absolutely.
Good. The first thing is 1 in 30 women on average under the age of 40 have an earlier menopause. It might be a surgical menopause. It could occur because their ovaries fail at a younger age. And those women absolutely need hormones for their future health. But the other thing is we're meddling with nature all the time because we're not meant to live as long as we do. We're now living on average 30 years menopausal, which often means that we have this increased risk of diseases. And if you look at our lifespan versus health span, the last 10 years of women's lives is often spent in poor health with inflammatory diseases, so heart disease, osteoporosis, diabetes, dementia, autoimmune diseases, and so forth. So we have to be thinking, why is this happening? Well, I've got a pathology degree. I did a lot of immunology as part of my degree. We know that our immune system can work against us and be pro-inflammatory. One of the things that increases inflammation in our bodies is low estradiol levels, low testosterone, low progesterone. The same way that if we eat an inflammatory diet, we eat processed foods, it will increase inflammation in our body. So I'm not saying everyone who's menopausal, not taking hormones, is going to have all these diseases, but there's an increased risk and it's up to them to decide how to reduce it. Lots of people say, well, it's just a natural process. Well, there are lots of things. Getting hypertension as we age is natural. Being in pain in childbirth is natural. And we just decide how we want to manage it.
And I suppose the point about autoimmune conditions is women tend to have a higher level of autoimmune conditions than men anyway.
Yeah, for sure they do. I don't know whether it's because they have low estrogen or low testosterone. Even conditions such as multiple sclerosis, testosterone is very important and helps with rebuilding myelin. And we know there's myelin degeneration with multiple sclerosis. I'm very interested in neurology and neurophysiology, and the role of our hormones as neurosteroids has just been forgotten for so long because menopause is always about periods. It's always about fertility and always about aging, but we're forgetting that they're biologically active hormones and also closely linked with cortisol, of course. Progesterone leads to cortisol production as well. So if we don't have the right level of hormones, we're going to have a different amount of cortisol. We're going to have more inflammation for so many reasons. So I think when anybody's thinking sort of knee-jerk, hormones cause cancer. But then if we take a step back, how can our physiological hormones cause cancer? You just go back to the basics, and that's where my pathology degree has allowed me the way of thinking to be a bit like an annoying 2-year-old going, but why is that happening? Why are we being told this? Does it really make sense? And often with this hormone, it doesn't make sense until you unpick it and realize they're actually talking about synthetic hormones, which are very different than natural hormones.
And I wonder, because the menopause can cause such a wide range of symptoms, does that make it difficult for GPs to sometimes identify what a female patient is telling them?
Oh, you know what? Absolutely. And I shudder when I think about patients I've seen over the last 25 years of being a GP. Never once did I think about hormones. The women with total body pain, with fibromyalgia, with worsening migraines, finding it very difficult to get out of bed because they've got joint pain, the ones who came in crying, with their low mood, the poor sleep, the dry eyes, the recurrent UTIs, palpitations. Because if you see it as one problem, one consultation, you absolutely are going to miss it.
Because, of course, a lot of times patients are told by their GPs, we can only discuss one problem.
Yeah, and I understand that as a GP, because if someone has got all these symptoms, where do you start? And one of the things that I wanted to do with Balance app, the free app, was that there's a symptom questionnaire and allow women to know, because then their one problem could be perimenopause or menopause or PMDD, hormonal change, rather than a myriad of symptoms. So then the GP or the healthcare professional quickly look at symptoms. And then we're quite used to dealing with uncertainty in general practice. The lady with poor memory and headaches, does she have a brain tumor, or is it her hormones, or is it both, or does she have clinical depression? And I always say to women, I have no idea how many of your symptoms are related to your hormones, but I do know that you're 45, 55, or whatever, your hormones are changing. I can help you rebalance them physiologically, and let's see what symptoms are left.
So if a woman is reporting depression, inability to sleep, various other factors, is there a risk that if the GP fails to recognise them, she then starts being given drugs for these various conditions, which may create problems of polypharmacy when patients fall into a cascade of being prescribed different drugs?
Yeah, we see this all the time. There's this whole talk, isn't there, like you were saying, about medicalising the menopause. It is being medicalised already, Liz. We see so many women, and I can't even begin to tell you how many, who are not only on antidepressants, they've tried 2, 3, 4. They're also on quetiapine. They're also on lithium. I have seen so many women who have been given ECT.
ECT?
Yeah.
Gosh.
And I've recently seen women who have had ketamine infusions. They cost about £8,000 course.
And there's no good evidence that ketamine works either.
No.
Also from horses, interestingly.
Isn't it interesting? But people are looking at it, and you're talking about making money from a private practice. It doesn't cost £8,000 to come and see me, by the way. And actually, we've just presented some data at a conference that are de-prescribing, because a lot of women come off these medications. I spoke to someone earlier this week who'd had 3 different episodes, 3 months at a time, in a secure unit under psychiatrist, age 49. She said one time she had beads of sweat pouring down her cheeks. She didn't know anything about menopause. It is traumatic stories I've heard, and I know it's related to hormones, because when we give them the hormones back, they improve.
And of course, if they're being put on these sorts of drugs, you've got to taper them off it very carefully. These drugs are not drugs you can just stop one day.
Absolutely not. We're very fortunate we have a psychiatrist who works in our clinic. She's an NHS psychiatrist who works with us as well. But the sad thing is that we know drugs such as quetiapine, as you know, will increase prolactin, which will then suppress FSH, which will then suppress estradiol, testosterone, and progesterone. So it's giving women a chemical menopause, actually. And then a lot of women, especially women I speak to, in prisons or people with learning disabilities, are given things like Depo-Provera, or they're given an implant to stop their period, to help with contraception. Of course, lovely, lovely. But all they're having is a chemical menopause, because they're blocking their natural hormones working. And then when they become very anxious, very low, they're not sleeping well, they become argumentative or irritable, then it's always, they've had stress or trauma. They're complicated people, Louise. They've got a personality disorder. Well, they might have all of that, but they've also got no hormones or very little in their brain. So let's think about why they've got dry, itchy skin and cystitis as well. We have to think about it in a joined up way.
So, Louise, as we head through the perimenopause and the menopause, the levels of 3 key hormones, estrogen, progesterone, and testosterone, will drop significantly. What's the most common form of HRT that you would be prescribing?
So I prescribe all 3 hormones, and I prescribe them separately. The reason I prescribe them separately is because that's the only way of having the natural body identical hormones. And we're all different. So some people respond really well with estrogen. Others won't respond to them until you add in progesterone. So even women who've had a hysterectomy, for example, can also benefit from progesterone. Testosterone is a really neglected hormone. Most of the studies have been done looking at libido, and don't get me wrong, libido is important, but actually so is having your mind back as well. We know that mental health improvements really are more significant with testosterone. A lot of people find their energy, their mood, their concentration really improve with testosterone. And got a podcast with a professor from America who clearly says he thinks the biggest marker of good health in men and women is their testosterone level. And he's onto something, because it's very anti-inflammatory. It can induce apoptosis, it can help with autophagy. It's a very important hormone that has been neglected, not just in women, though, Liz, in men as well, actually.
So just looking at each of these hormones in a bit more detail, what happens when our estrogen level drops in our body? What do we need it for? And what happens if we haven't got enough of it?
Yes. So estradiol, and when I say estradiol, it's important because estrogen can mean different things. We've got estrone, which is an inflammatory type of estrogen, or estradiol, which is the anti-inflammatory estrogen that we produce mostly when we're younger. Our fat cells produce estrone, which is pro-inflammatory, very weak type of estrogen, not as good. So estradiol works on every cell in our body. It's a hormone, obviously a chemical messenger, but it actually helps with so many processes in the cells, including mitochondrial function as well. And we know that the mitochondria are a powerhouse of all our cells. It also improves the way our immune system works. It helps the cardiovascular system. It will help nitric oxide production. It will help reduce inflammation in the endothelium. It will cause vasodilation, angiotensin system. So it will help lower blood pressure, the natural vasodilator. In the brain, it works as a neurotransmitter. So when we have estradiol, we have higher levels of dopamine and serotonin and glutamate in our brains as well. It also works to improve the conduction between our synapses, helps with neuroplasticity, helps reduce tau protein and amyloid in the brain. It helps build myelin. I can pick any organ, tell you how it works. Estradiol has been spoken about as nature's psychoprotectant. It helps every single area in our brain, but those areas that help determine our mood, our personality, our memory, but also our heart rate, our respiratory rate, even the way that our liver works and our metabolism. So it's just been seen as a hot flashes type of problem.
Because it also is involved in temperature control.
Of course it is. So it affects the thermoregulatory part of the brain. But the reason it's so focused on a hot flashes, which I only realised recently, is when they started doing studies in the 30s and 40s, when they discovered hormones, they realised it was one of the symptoms that they could measure with a clipboard. It was an objective measurement. They could see people flushing and sweat. So the male researchers decided that was the most important, because the other symptoms, mostly psychological, they could be made up by women. So they were dismissed. And it's carried on now. You only need to look at the NICE guidance. It will say vasomotor symptoms, vaginal dryness. They do say mood changes. But all the other symptoms like joint pains, dry eyes, dry skin, burning mouth, whatever, it's just been ignored because the research decided that they were too subjective.
And of course, there are a number of different ways of taking this, whether the pills, patches, gels, sprays. How do you decide what's the most appropriate?
So usually transdermal, because when it goes through the skin, it goes into the bloodstream, doesn't need metabolizing, so it doesn't have to be metabolized by the liver, so there's no risk of clot or stroke. And so it's most physiological. So estradiol I usually offer, and it's a patient choice between a patch and a gel. We have a spray, but I find in my clinical practice it's not very well absorbed. And then progesterone, we give the natural micronized progesterone, so it's usually an oral capsule. It can be used off license vaginally, or there's cyclogest, which is actually made for the vagina. And then testosterone, not licensed for women, of course, but licensed for men. So that's either a gel or there is a cream that is licensed in Australia, but it's only available privately so far.
So progesterone, what does that control in our body, and what happens when we haven't got enough of it?
So progesterone is a very calming anti-inflammatory hormone. It's produced in our brain as well as from our ovaries. And again, we've got cells that respond to progesterone all over our body. Very similar effects, because obviously it's very similar to estradiol. But a lot of people find that they're more relaxed, they sleep better, they think clearer. It can also help build bone. It can also help with our cardiovascular system as well. So lots of effects. And sadly, I wasn't taught this. I was always taught it's just to protect the womb if women are on estrogen. So don't bother if people don't have a womb. But it can be very good. And actually, one of the first things that our brain does if we had a stroke or a subarachnoid or a brain injury is it actually produces progesterone. So it's very anti-inflammatory in the brain. It's very repairing in the brain as well. Our brain cells, our glial cells, our dendrocytes, they produce progesterone as well. So it also begs the question, why are we not researching this in men as well? Because they produce progesterone. So it's a very interesting hormone that's just been neglected for so long.
And Louise, what about testosterone? What are its benefits?
Huge benefits. Again, testosterone affects every single cell in the body. It's the most biologically active hormone that we have when we're younger. So it can work on the cardiovascular system, it can work on the bones, it can work on the genitourinary system. Really important to see lots of women with recurrent cystitis, chronic pelvic pain, painful bladder syndrome that really improve with testosterone. On our skin, it has an effect. Our hair, it has an effect. Eyes as well. A lot of people with dry eyes really improve with testosterone. So it affects everywhere. But again, it's very anti-inflammatory as well. And this low-grade inflammation that is linked with diseases.
I suppose people have only been taking these bioidentical hormones for a relatively short period of time. Is it possible that long-term risks may emerge that have not yet?
So they have been around for a long time, actually. Progesterone was first found in the 40s and 50s, but there was a big move to push to synthetic because it meant that pharma could sell them and make a lot more money out of them very quickly. And they could be made in a laboratory. when the contraceptive pill came out, there was hardly any studies, and the studies were done on the endometrium, not even on fertility. They were pushed out very quickly, and they've still not looked at effects on the brain or the bones. You know, we know that the Depo-Provera injection can increase osteoporosis. We know a lot of women are co-prescribed antidepressants. So actually, there's been very little research that's good quality on the synthetic hormones. It's a real problem with the synthetic hormones. The natural hormones have been around, but they've been ignored because more money can be made, more mass produced can be made by the synthetic hormones, especially the contraceptive. But actually, when we know that they work in the same way, how could they be at risk, if you see what I mean? It just doesn't make sense.
Well, because I suppose you'd be taking them at a point when naturally these hormone levels will be dropping in your body.
Yes, if you compare it with thyroxine,
which is for people who have a thyroid deficiency.
Yeah. Who has decided that we are allowed to have thyroxine in the long term, but women have to stop hormones? And what's very interesting also is there's been so much attention on the ovaries for so long, but there are a lot of women I see who are young, a lot of women with PMDD, and that's more of a brain condition. So we're forgetting really about the whole systemic effects of hormones. And a lot of women I see, myself included, wish they'd started taking hormones a lot earlier. But a lot of symptoms were just a bit of low mood, a bit of not sleep very well, a bit of overwhelming, a bit of multitasking not being quite as good as it was before. And this is where the whole problem is. It's become an ethical debate. It's become a social debate. It's become a biological debate. And I think we'll never have all the answers. But why are we scrutinizing that when we can give antidepressants long term that have a higher risk of osteoporosis, more likely to be addicted?
I guess any treatment, you have to weigh up the benefits versus the risks, don't you?
Of course you do. Absolutely do.
Which sadly doesn't happen in a lot of cases. And so what you're saying is there's clearly tremendous benefit. I guess it's possible there might be some risks that we don't yet know about.
A risk of unnatural hormones, of course there might be, but it's very unusual, isn't it? But even if you look at the studies, look at the WHI study.
The Women's Health Initiative study.
The Women's Health Initiative study. And even if you look at some of the interpretations, they did another analysis in 2019 of it and showed that the risk was even higher than they thought before. But let's quantify that risk. Firstly, that risk wasn't with estrogen only HRT, it was estrogen and the progesterone acetate, the synthetic progesterone. But that risk is still low. It wasn't statistically significant. Compare it with other risk factors for breast cancer. So the risk was lower with that than it was for women who drink moderate amounts of alcohol, who don't exercise, or are overweight. Now, we make a choice what we eat. I can choose what I eat. It's up to me. As long as I know that if I eat processed foods, I've got an increased risk of obesity, inflammation in my body. That's up to me. So I could decide, well, I'll take HRT. Maybe there's a risk. The study showing the biggest risk actually is still quite low. But we've known since 1941, Professor Albright clearly showed that people who take hormones have a reduction in osteoporosis. They have more bone density, and that's obvious because we've got these receptors. As a menopausal woman myself, I'm very scared about osteoporosis, especially of my spine. 1 in 2 menopausal women not taking hormones will have osteoporosis. So as a consenting adult, I have decided I want something that's going to reduce my risk of osteoporosis. I don't want bisphosphonate.
Which is a drug used to treat osteoporosis.
Yeah, or any of the new drugs, because there's no long-term data on them and I don't like the way that they work.
And actually, for some women experience more bone breaks on them.
Yes, precisely. I don't want to have an atypical fracture. So I'm just weighing it all up in my mind.
So what hormones do you take?
So I take all three. I take estrogen, progesterone, and testosterone. And I also use vaginal progesterone, which is DHEA, which converts to estrogen and progesterone. And if I don't use that, I get such awful recurrent UTI. It's terrible.
So would you argue that really most menopausal women should be taking HRT?
No, I would argue that, I wouldn't argue, I'm not really that argumentative. I would say, and I do say that I think all women should have knowledge and they can make choices. And I do very strongly, though, feel and argue that 100% of women who want to take hormones should be able to have it. Now, you only need to look on my social media or just listen to women, and they'll tell you that all they're being offered is antidepressants instead of hormones. They want hormones, but they're being told they're too fat, they're too thin, they're too old, they're too young, they're too whatever. And so I feel that women should be allowed choice. That's the most important thing. And if it's only a minority of women that want hormones, that's fine. Like, it's absolutely fine. But I think what's happened is there's been this void since the WHO, the Women's Health Initiative study. And so people have then medicalized in different ways. And a lot of women, they say, no, I'm through the menopause, I have no symptoms. And then you ask, what's your sleep like? Do you have any muscle and joint pains? Do you have any urinary symptoms? And then they go, oh, yeah, but that's part of just being older. And often it isn't. And the other thing is, when you look at population health, most women die from heart disease and dementia. We've got good data that women taking hormones reduce their risk of a heart attack by about 50%, better than statins. We've got very little evidence for primary prevention for women taking statins. So that, again, is thinking, actually, women in deprived areas who are more at risk of heart disease, more at risk of diabetes, these women are less likely to get hormones, but more likely to be on antidepressants and statins and blood pressure treatments.
I did a podcast on statins a while ago, and there was actually no difference in the risk of a fatal heart attack or stroke for low-risk women, whether they were taking statins or not, and a very small reduction in the chance of a non-fatal heart attack or stroke for those women taking statins.
Yeah, for primary prevention. And so that's where looking at the bigger picture, and it's also spinning it on the plate a bit and thinking, what are the risks of not having hormones? You know, we all talk about the risks of medication, but it's like, what are the risks of not having it? And again, are you happy to have this increased risk? Because some women go, do you know what? I have no symptoms. My diet is brilliant. I exercise. That's fine. They've made that choice, and it's an informed choice. And that's absolutely fine.
And Louise, presumably, just because you're taking HRT doesn't mean that you don't also have to eat well, exercise, etc.
Yeah. I never did yoga. I don't drink alcohol or caffeine, but if I did, if I ate McDonald's for lunch, of course I'm not going to be as healthy. I can't expect hormones to do everything.
I think there's also been this idea that if you are going to have HRT, you need to start it in your 40s and 50s, and you can't start it if you're older. But you would argue, well, not argue, but you would say that's not the case.
So I wouldn't prescribe conjugated equine estrogens with synthetic progesterone as a tablet to older women. I wouldn't prescribe it to anybody. But the reason people say you can't have older, because there is a risk of heart disease, maybe a risk of breast cancer, risk of clot and stroke with these synthetic hormones. Giving the natural hormones, yes, and I do start them in older women on a lower dose, because we know even lower doses are bone protective as well. And I've got people who I've seen who have early cognitive decline, early dementia, and they've been stabilized with their mood on just a low dose of hormones as well. So we shouldn't be denying women. And the other thing is the vaginal hormones do not get systemically absorbed. So women who have recurrent UTIs like me, so we have to think about vaginal hormones, because about 30% of sepsis is due to urosepsis. So the number of women I used to visit with recurrent urinary tract infections as a doctor in nursing homes, and never once did I give them vaginal hormones. I didn't think about it, Liz, but really important and very safe, because they don't get absorbed systemically, so they can be given with or without hormones, but we can't ignore that as well.
So you would start older women on lower levels. Would the proportion of the different hormones you give likely to be different in older women?
Yeah, it really depends on the women. We often start with obviously estrogen and progesterone if they've got a womb. And then the need for testosterone varies. I mean, the guidelines are very clear that if women have reduced sexual desire, they can be considered with testosterone. Many women have reduced sexual desire, but a lot of women notice that their stamina, their ability to function, their muscle strength. I worry a lot about osteosarcopenia. I've already said about the bone bit, the osteoporosis. But sarcopenia is this loss of muscle mass that people have. And this is why people are finding it difficult to get out of the bath, get out of chairs, not use their Zimmer frames, they trip on the carpet. You can see it happening a lot. And so we want to keep our muscles strong. Obviously, we need to do appropriate exercise. But without all three hormones, where we've got receptors in our muscles, then you will get loss of muscle mass often for women. We can't just think about its symptoms, thinking about their biological effects and how they can help.
And what's the oldest patient you started on HRT?
So a few years ago, a lady for her 90th birthday treated herself to an appointment. So she came in and started HRT, and then 6 weeks later, she phoned up and she said, I feel great. Can I start some testosterone?
And what sort of improvement did she see?
She could sleep better. She could jump out of bed. She had less muscle and joint pain. She had more clarity in her mind. She found that she had some indigestion, which reduced. Her muscle strength improved. She had urinary symptoms as well. So she just felt so much better. But she's someone who had been on HRT, taken off because of the Women's Health Initiative study, and told she could never have hormones again. She did her own, research, reading, and decided she wanted to try. The other thing is to remind people that hormones don't work very long in the body. So if I took my patches off now, tomorrow they'd be out of my system. And I know that very clearly because I forgot to change them recently on a holiday. The evening, my children were saying to me, what's wrong with you? Why are you so vacant? What's going on? And then I realized, so the half-life is very low, doesn't build up in the body. And that, again, is really important for women to know that if they start something, they don't have to continue it. They are in control of what they're taking. And that's so crucially important.
And of course, the point about potential brain health, given the currently available dementia drugs, which are pretty unsuccessful and have very nasty side effects of bleed to the brain, this seems an obvious thing to be exploring in the older population.
Totally. I've got some reports from a meeting that was held in 1972 about the anti-aging effects of our hormones. We know that it will reduce incidence of dementia, but now it becomes very political, and there are studies showing increased incidence of dementia, but that's with the synthetic hormones. So it's like comparing apples and bananas because they're fruit, and saying all fruit is yellow because I picked the yellow banana. So if you tease it out, bring it back to basics, this is where I get frustrated because it's such simplistic medicine. And I don't know whether it's because it's about women or it's about control or the patriarchy way that medicine is. I don't really get it.
But I also think if most women in their 60s, 70s or 80s went to their GP and said they wanted to go on to HRT, they'd be told this is simply not an option.
Well, it really varies, actually. And I think times are changing. So I think there's still a lot of doctors that will say that, but there's a lot more that will consider it. Our education program that we developed has had over 33,000 downloads. I'm presenting at the Royal College of GPs, a couple of abstracts in a few weeks' time. When I usually go to these meetings, there's a real mixture of people. There's those people that look at me and probably want to spit in my face. And there are others, especially younger doctors, that come up to me with the utmost respect. They often want selfies. They say, Louise, you've transformed the way I work. It's so wonderful to be able to offer and give women something. And they're seeing the results. And in medicine, it's a science and an art. We learn the science, but the art is individualizing care and learning from clinical experience as well. So there is a shift, and the shift seems more, even than when we met in London those few months ago, people are understanding it. They're just reading it for themselves. And to be a good doctor, you've got to be an inquisitive doctor. And the problem is so many doctors and clinicians are really burnt out. They're exhausted. They don't want this X work. But quite quickly, they'll see that if they do invest a bit of time with women, the women won't be coming back with all the symptoms. They won't be coming back with their long list. They won't be needing different investigations, cost the NHS money. They won't be leaving their jobs. They'll be putting more money into the economy. So I think people are working it out. But when you change any process, it takes a long time, doesn't it?
Absolutely. So long-term, potentially, it reduces patient load.
Yeah, so we did a survey a while ago, a couple of years ago. We found that 17% of women who come to our clinic had seen at least 10 GPs in the year before.
Gosh.
The year after, it had dropped to 0.1%.
But if I was an older woman who wanted to have HRT, I think I'd want to go to a specialist clinic because I would be concerned that my GP wouldn't necessarily have the knowledge to prescribe it at the appropriate levels and the right proportions.
Yeah, so we've got an easy HRT prescribing guide. You can just Google Newson HRT prescribing that I've written that's evidence-based. A lot of clinicians use it, but also a lot of women use it and then say, actually, I would like this and this. And like last night, I did a webinar for healthcare professionals, lots of information, lots of questions. I mentored lots of people. So lots of doctors contact me. I've seen this patient. I give them a ring. I know they'll help that patient, but they'll help the next 20 as well. So I think in the past, menopause has been quite a Cinderella specialty. It's been owned by gynecologists. I'd be naive if I thought my clinic could mop up 14 million menopausal women in the UK. That's just ridiculous. And actually, my measure of success would be closing the clinic because no one needs to come because they're getting it in the NHS. So that's why we work so hard to help people in other ways.
For women who've had breast cancer, how does that change things?
A lot of it is due to uncertainty because we don't have good evidence. And it's very interesting there because we've got estrogen receptor negative and positive breast cancers. A lot of people think if it's estrogen receptor positive, it's been caused by estrogen. I've already said earlier in this podcast, we have estrogen receptors everywhere. So, of course, breast cancer will have estrogen, progesterone, testosterone receptors, but it doesn't mean it's a negative thing. And we have to remember before tamoxifen, they gave quite high dose oral estrogen. It's actually a treatment for breast cancer, especially fungating breast cancer. So we don't know because we haven't got good studies. The studies that were done were stopped early because of the Women's Health Initiative study. And a lot of them were using synthetic hormones, which again are going to be different. So then what do? Do you wait for a randomized controlled study that's not even started yet? When you've got a patient sitting in front of you saying, I'm existing, I'm not living, the joy of my life has gone. I would go through breast cancer treatment again if it meant that I would feel better. So then what do you do in that clinical situation? So you share uncertainty. You talk about the symptoms, see what else they've tried, any other non-hormonal treatments, lifestyle, everything else. Sometimes we give testosterone rather than the estrogen and see if that would improve their symptoms enough because the oncologists are often more concerned about blocking estrogen. People are on aromatase inhibitor, then there's some evidence aromatase inhibitor with testosterone can actually be beneficial for their breast cancer as well.
For postmenopausal women who've had breast cancer, for 5 years they take an aromatase inhibitor.
Often, and often don't because the side effects are so extreme.
But for those who do.
For those that do, and then tamoxifen is interesting because, as you know, it's a selective estrogen receptor modulator. Bit of a mouthful, but it could be anti-estrogen on the breast, pro-estrogen, for example, in other areas of the body. And so there are studies that show quite a few women on tamoxifen have raised levels of estradiol in their body anyway. So some people are more comfortable giving HRT to those women who've had estrogen receptor negative breast cancer. Most people are more confident and comfortable giving estrogen. I see women who've had breast cancer like 25 years ago. And so their risk of recurrence is very low. I saw someone in my clinic yesterday who's 47. She had breast cancer 10 years ago. Periods had come back naturally after all her treatments. Then she'd become perimenopausal. And then she actually had her womb and ovaries removed because she's got BRCA gene, but was told she can never, ever have hormones. Well, she could have carried on with her periods for another few years. No one would have minded. But it's something people get very scared. So it's very individualized. We're just writing up a huge amount of work. It's a consent statement. So we've worked with oncologists, breast nurses, menopause specialists, breast surgeons, looking at all the data and looking at benefits as well, because whether women have had breast cancer or not, there are benefits to our bones, heart, brain of taking hormones. Some women say, I'm more worried about my risk of osteoporosis than I am about my risk of recurrence. So therefore, I would like a treatment that's going to improve my bones. So it's very, very individualized. But vaginal hormones can be given to women who've had breast cancer very safely because they work locally, so they don't work systemically.
Presumably taking testosterone isn't likely to have any breast cancer risk.
No, it's not likely to at all. It doesn't work, obviously, on estrogen receptors, and it has been shown in some small studies that it can improve prognosis actually after breast cancer. And so increasingly, I will start with testosterone, but it's very, very individualized because there's so much uncertainty, but I'm quite confident sharing uncertainty with patients. I'm very fortunate. I don't know what it's like to have had breast cancer, but I also don't know what it's like to suffer with menopause in these individual patients. And some women are fine, but those that aren't, I just think it's too cruel to watch them suffer, knowing that they can have a treatment. So I always say to them, try it for 3 months, doesn't make much difference, then you don't have to continue. But a lot of women say, I've got my life back. I might have shortened my life. I might have a risk of recurrence. But you know what? Every day I wake up and I'm happy, which I haven't done for years.
So if there is a risk, it's more likely to be a risk with estrogen and progesterone.
Yeah. Progesterone, again, is very anti-inflammatory. I wanted to do oncology, so I worked a lot in breast clinic many years ago, but they used to give high dose hydroxyprogesterone acetate actually for women who had resistant disease. So it's interesting. I think we don't know enough about breast cancer. Really simplistic to talk about estrogen being so awful. Yet a lot of these women post breast cancer put on weight. They've got more estrogen in their body from their factor. So if I had a choice, and we're doing some work with a Spanish researcher at the minute, between having estrone and estradiol, give me estradiol every time.
Now, you mentioned tamoxifen. That was historically one of the inhibitors given. Now, for example, arimidex is very commonly given. Does that have a different impact?
Yeah, definitely. Aromatase inhibitor is like squeezing every last cell of estrogen out of the body, whereas tamoxifen has this pro-estrogen and anti-estrogen effect. Side effects can be so much more extreme.
But I meant in terms of how it impacts with HRT.
Yeah, so there's no point giving estrogen to women who are on aromatase inhibitor because it won't work.
But you could give them testosterone.
You could give them testosterone, yeah. It really varies. Some people, they might decide to have like a 6 weeks break from their aromatase inhibitor and find that the side effects from their aromatase inhibitor rather than the menopause. Or they might change to different aromatase inhibitor, or they might change to tamoxifen. And then they say, gosh, I feel so much better. I don't need any hormones.
So if I make you health czar tomorrow in the NHS, how are you going to change how we treat women who hit the menopause?
The first thing you need to think about, could any of this be related to hormones rather than waiting for it to be the last diagnosis? Be on hyper alert, because once you see it, you won't unsee it. Remember how cheap HRT is and remember how safe. Make sure you've got really clear guidelines, that you're well supported. And then think about other medications. We're medicalizing too many ill people with the wrong medicines at the minute.
So that was the first part of Louise's interview. The second deals with questions that the BBC Panorama programme raised. One of the points it reported was that the British Menopause Society, or BMS for short, had removed Louise as a specialist. But I think it's important to remember that this is not an official accrediting body, but a charity. And while I don't know the full details of the relationship between the Newson Clinic and the BMS, it seems an uncomfortable one. For example, Louise alleges that when she set up a menopause website some 8 years ago, the society told her to take it down because a second menopause website wasn't needed. I started my second conversation with Louise asking her about what has now become a contentious issue and was raised by the Panorama programme: why she sometimes prescribes higher levels of estradiol.
Firstly, there's nothing in any guidelines talking about dose. It's just what's licensed in the UK. And as you know, licensing, they give a dose and an indication just to get through the license. And there's lots of things in medicine we prescribe off license, as in for different indications. And there are drugs that we can give doses off license as well. It's just the way they've been licensed. So when we use estradiol through the skin as a patch or gel, there is a spray, but I tend not to use it because it doesn't really get absorbed very well. We're basically using the skin as a vehicle to get the substance through the skin. Now, as you know, Liz, our skin is a barrier. We don't put on sun cream and expect it to get into our bloodstream. So our skin type, texture, vasculature, temperature really varies. And so therefore absorption of anything through the skin will vary. So it's the same with transdermal preparations. In the patches, the glue contains the estradiol. And if it's not sticking on very well, you're not going to get as much absorbed. So often we give higher doses to women who aren't absorbing very well. So we're not giving higher doses to get higher quantities in the body. We're just giving it to have a physiological response. And some people, we don't increase the dose, we might change preparation. So some people find that one type of patch doesn't stick as well as others. Some find that the gel is preferable compared to the patch. So all our consultations obviously are individual. But the irony is So 8 years ago, when I started HRT, I didn't feel any better a few weeks after taking it, and my estradiol level had not increased. So my consultant doubled my dose. So I was on 200 micrograms. I said to him, well, that's a bit high. And he said, well, Louise, you're just not absorbing it. Your level's low. You tell me your practice isn't sticking on particularly well. We'll just increase it. And then my level went up. It's never been particularly high. And with time, it's been increased further because I was perimenopausal when I started HRT, and now I'm sure I'm menopausal. So it's really interesting. So when you look at the studies that the drug companies use to license this dose, I've got a whole table of all the different studies, and they're all done on less than 40 women. And most of them are done in less than a week. Some are 4 days, some are 7 days. They're just testing to see, does it stick on? Is there some absorption? And even those studies show there was about a 16% of women didn't absorb the dose the same as others. But obviously, we assess people for longer than 4 to 7 days.
Because people take these hormones for years and years.
Absolutely. But we also know even the International Menopause Society white paper that came out recently said there's 10-fold variation in absorption. And we know from some of the studies that there's a 22-fold variation depending on whether you put it on your back or your bottom or your thigh, because our skin is different in different areas of our body as well. And it has to get through the skin, then it has to be absorbed properly, then it's metabolized. So we often use estradiol levels as blood tests to see if people are absorbing. So if someone comes back to the clinic, their levels are low and they're experiencing symptoms, then we increase the dose so they can get adequate amount through their body. Because as you know, if you have low estradiol, you've got still increased inflammation in the body and risk of future diseases, as well as having symptoms, if you see what I mean. So there are risks of not having enough for the right person. 52% of women who come to our clinic are already taking HRT. They don't come because they want to spend money. They come because they're experiencing symptoms that are affecting the quality of their lives. Their NHS provider is not giving them the treatment that they want.
And it's possible that the subgroup that you see of people who struggle with standard HRT may therefore be people who are poorer absorbers.
Yeah, so there's two things with our patients. There are those that are poor absorbers, and we see a lot of people from psychiatric hospitals. I have lost count the number of women I've seen who have had ECT, electro-convulsive therapy, on quetiapine and heavy-duty drugs, but also increasingly women who have had ketamine infusions without anyone thinking about hormones. There was a study in 1970s, it was an RCT actually, and it was giving 25 milligrams of oral estradiol. So that's 12 times higher dose. And those women responded really well. And so there might be something, and we don't know because no one's done enough studies, to show that women who have higher doses into their brain, so get through their blood-brain barrier, do well. So the irony is we have no idea what doses we should be giving. But the other thing I think to reassure people is if you look at the dose, even 300 micrograms of estradiol, which is what I'm on, I've been prescribed, is still lower than the equivalent dose of any ethinyl estradiol, synthetic estrogen in any contraception pill. We can't have double standards here. We can't be worried about menopausal women taking natural estradiol and not worry about younger people on contraception with synthetic hormones, which we know have risks to the body.
Does it make a difference, though, that you're dealing with an older age group in the postmenopausal women rather than the women who are on the contraceptive pill?
No. So there's two things there. We see younger people as well. You have early menopause. So I have patients in their 20s and 30s and 40s. And we know that those women often need higher doses. So that's one thing. But the other thing, the risks are always there. So there's risks of contraceptive, synthetic hormones, synthetic older types of HRT, including risk of clot and stroke and heart disease. Now, those risks are not there of heart disease and stroke and clot on women of any age. And that's why the natural hormones, when you look physiologically in their body, they work very differently. So it wouldn't have any increased risk. And also, there's no study that shows that even if someone has a higher level of estradiol in their body, that it's dangerous.
I interviewed a doctor recently. She works with patients with early dementia. As part of that program, they give hormones to balance the brain. And she says for people who don't appear to be absorbing well and she's not getting results, sometimes she checks their hormone metabolites as well. Because sometimes if these are higher, perhaps those patients don't need such a high dose of estrogen.
Yeah, so some people have metabolites done, but it's usually done in private clinics and they're frightfully expensive. And I'm not aware that there's enough evidence to support their use generally. So the other thing when you look at hormones, when people don't metabolize properly, if their liver's not working properly, It's actually not just doing tests, it's looking at what's their nutrition like. Are they having processed foods? Have they got inflammatory foods in their diet? Are they drinking? Are they smoking? What's their stress like? I don't need a fancy test to tell me that. So a lot of people find that just looking at simple measures about the food that they take can really change the way that the hormones work in their body. And as GPs, we're very used to dealing holistically to patients. So it's not just giving a dose of HRT and then forgetting who we're giving it to. We spend a lot of time in the clinic talking about what else they're doing, what they're eating, what other supplements they're having, what their exercise is like, what their stress levels like, what their sleep's like, all of that. And of course, that's going to interfere and affect the metabolism of their hormones.
And the other issue that's been raised is how much progesterone you should be taking, and that some people feel that if your estrogen level goes up, your progesterone should go up as well.
Yeah, and again, I think people aren't thinking basically, because some of the reasons, like I say, we give higher doses was to absorb an adequate amount. So I might be using, well, I've told you I use 300, but my estradiol levels are always low. So I'm probably absorbing less than somebody who might be on 50 micrograms who's absorbing well. We've been looking at our data, and we presented some at the British Society of Gynecological Cancer of our endometrial thickness of women who bleed, looking at doses. And actually people on lower doses have thickened endometrium than women on a higher dose. And it's probably the whole absorption issue. So when we give doses, it's according to clinical response and need. So some people who have lower doses need higher doses of progesterone than others are on higher doses, because it depends on the absorption. There are some women we see who have quite low absorption, they're on lower doses, and their endometrium becomes quite almost unstable. They bleed a lot. They might have a normal scan, and then we'll increase the estradiol and their bleeding settles. We have to remember also, just blanket given double dose of progesterone, that's an off-license dose. So we're sort of worried about estradiol, but we're not worried about progesterone. I don't really understand the logic behind that either. So I don't see why we have to just give more progesterone. Some women we give more progesterone to because they have more benefits from it. But I've seen and spoken to a lot of women who say, my doctor's just knee-jerk increase. I've been on the same dose for the last 5 years. Because what the British Menopausal Society say, I've doubled my dose. I'm so sleepy, I can't function in the daytime, but they tell me I have to take it. There is absolutely no evidence having a higher dose of progesterone with a higher dose of estrogen is beneficial. So the bleeding guidelines from British Menopausal Society are more of a consensus statement. They're not based on solid evidence. And when we don't have solid evidence, we use common sense. We're allowed to, medicine is an art as well as a science. And so it's individualizing care and looking at the balance of the hormones. And sometimes we give the same dose, but we change it from oral to vaginally if people are bleeding and their endometrial thickness is normal, because bleeding is a nuisance, but you don't want to just stop hormones. And we also know that anyone who takes continuous HRT, so estrogen and progesterone, have a lower risk of endometrial cancer compared to people who don't take HRT. So it's assessing the patients as individuals, which is what we should do in anything in medicine.
Would there ever be a case for giving people lower levels of progesterone than the minimum recommended level?
I don't think so. Progesterone is a bit of a marmite for some people. Some people love it and some people don't. I do have some people who just can't tolerate it at all, and we try it vaginally. I've even got some patients who've had a hysterectomy because they can't tolerate progesterone, but they want the benefits of estradiol and testosterone. There are ways around it often, but again, it's just going through and treating each patient as an individual.
Now, interesting, it just crossed my desk this morning, a Medscape article looking at different recent studies on HRT for dementia and arguing that there are studies that both suggest an increased risk and those that show a reduced risk. So for patients looking at all of that, I think that's quite confusing.
Yeah, and I think this is where you have to look at the evidence really carefully. If you look at the studies of dementia, a lot of them are with synthetic hormones as well. So conjugated equine estrogens and especially synthetic progestrogens, medroxyprogesterone acetate, which we know have risks associated with them. But this is where I think people have to look at basic pathophysiology. Look at the role of hormones in our brains, estradiol, progesterone, testosterone. We've even known since 1972, there was a big aging conference looking at the role of hormones and showing how dementia reduces. But you look at Lisa Mosconi's work looking at natural estradiol, but just look at the role of estradiol, progesterone, testosterone, how they work as neurotransmitters. They affect neuroplasticity. They affect myelin growth. They affect how the synapses work. They can regenerate nerves.
But I think there was a fairly recent Danish observational study.
It's an observational study. Even the conclusion said, we can't make any conclusions from this study. So it should never have been published because it's confusing and it does group the synthetic hormones as well. So it just adds more confusion to women. You don't always need a randomized controlled study for basic, obvious things in medicine.
You've talked a lot about the advantage of the bioidentical hormones. Are they absolutely the same thing? They're manufactured from plants. So are they chemically identical to the ones that our bodies produce?
Yes. So structurally, biochemically, they are the same structure. And that's crucially important. Even if you look at testosterone, all the confusion with testosterone being an anabolic steroid affecting hematocrit, these are all synthetic testosterones that have been chemically altered. And of course, they're not going to work the same in the receptors and they're going to have different effects. And it's really important when we think about every time we prescribe contraception, how different they are and the risks are different and the side effects are different. But the problem is everyone groups hormones together. I'm very interested in the immune modulating effects of hormones and the role of macrophages and mitochondria. But sadly, a lot of gynecologists don't spend their lives reading papers about mitochondria and macrophages that I do. But if you're confused in medicine, go back to the basics. And I think that's what's forgotten sometimes because they're just hormones, you know?
So are these bioidentical hormones isomers of what we produce in our bodies, or are they absolutely the same?
No, it's exactly the same. Yeah, exactly the same.
And finally, it's been suggested that all women on HRT, particularly those in higher doses, should have an annual ultrasound to check their womb and ovaries. Do you think that's necessary?
I mean, that's not recommended anywhere at all. And what a ridiculous waste of resources for that.
There's a menopause clinic that's suggesting that.
That's just ridiculous because what are we worrying about here? So if people bleed, most people who bleed do not have endometrial cancer. I've already said the incidence of endometrial cancer is lower in women who take HRT. And even the gynecologist telling us that there's more people going with bleeding to clinics, they haven't seen an increased incidence of endometrial cancer. Ovarian cancer doesn't increase with HRT. So why are we scanning people? And the problem is if you scan people without symptoms, what happens to those people that you see a polyp or a fibroid? Do you then do a biopsy? What do you do? People seem to be very worried about hyperplasia, which isn't a pathological condition. It's a physiological condition that can occur. The important thing is to have the right balance of hormones and monitor women. But if we're going to do that, we should be doing investigations on women taking contraception who have bleeding, who have irregular bleeding, who have altered cycle patterns, because there's more risk with those women. But we don't somehow. We ignore those. So I just think that would be a waste of resources and cause anxiety in people as well.
Louise, thank you so much for sparing the time to talk today.
Thanks, Liz.
Bye-bye. Hope you enjoyed the latest episode of the podcast. And if you've enjoyed the podcast, if you could share it and leave a review on Spotify and Apple, I'd much appreciate it. It really helps. Many thanks for listening. Bye for now.